Okay, welcome back everyone. Let's dive right into this explainer for part 11 of our masterclass. Now, if you were with us for part 10, you know we tackled partial mastectomies and lumpectomies. But today we're taking a massive step up. We're escalating to the complex coding world of total and radical breast procedures. This is the exact space where knowing your anatomical boundaries and tracking specific muscle or node resections will absolutely make or break your CPT code selection.
Since medical coding is so strictly rules-based, here's our roadmap for today. We'll hit 1. Anatomy and axillary nodes. 2. The mastectomy CPT code hierarchy. 3. Modifiers and unbundling traps. 4. Operative report case studies. And 5. Our masterclass summary and teaser.
But before we really get going, I want you to think about this specific surgical scenario. Imagine your surgeon removes level 2 nodes but explicitly spares the pectoralis major muscle. What mastectomy code are you reporting? If you're drawing a blank, don't worry. By the end of this explainer, you'll be able to code that scenario immediately, confidently, and with zero hesitation.
All right, Section 1. Anatomy and axillary nodes. The pectoralis and nodal map.
We always have to anchor our coding in anatomy. It's all about that clear, layered relationship between the breast tissue and the underlying muscles. Think of it like a structural foundation. You've got the breast tissue resting right there on the anterior thoracic wall. Beneath that is the large pectoralis major muscle, and tucked just beneath that is the smaller pectoralis minor. When you're combing through an operative report, isolating exactly which of these muscular layers the surgeon dissects or removes is basically what dictates your exact CPT choice. Now, as we move laterally toward the underarm or the axilla, we have to precisely map out the axillary lymph nodes. Think of these as your surgical checkpoints. The lymphatic system naturally drains from the breast into these exact nodes, and surgically, they're categorized into 3 distinct levels based entirely on where they sit relative to the pectoralis minor muscle. So, the crucial takeaway here is that the pectoralis minor acts as our anchor point. Level I nodes are located inferior, meaning below, the lower edge of that muscle. Level 2 nodes are deep or posterior to it, and level 3, those apical nodes, sit superior to the pectoralis minor. When your op report details a formal axillary lymph node dissection, knowing these levels helps you confirm the true physical extent of the procedure.
Moving on to Section 2, Mastectomy CPT code hierarchy, escalating complexity.
With our anatomical map set, it's time to see how surgical complexity translates into our CPT hierarchy. It's really a ladder. As the surgeon removes more anatomy, our codes escalate right along with it. We start at Step 1 with this simple complete mastectomy, CPT 19303. That's total excision of breast tissue but no formal axillary dissection. Step 2 escalates to the modified radical, 19307. Step 3 is your traditional radical mastectomy, 19305. And finally, Step 4 is the most extensive, the urban radical, 19306.
Let's stop and compare what are probably the 2 most confused codes in breast surgery, 19307 and 19305. Look, the modified radical, 19307, includes the axillary lymph nodes and might even take the pectoralis minor, but it specifically and explicitly spares the pectoralis major muscle. In stark contrast, the traditional Halsted radical, 19305, removes the breast, the axillary nodes, and both the pectoralis major and minor muscles en bloc. That pectoralis major? That is your absolute key differentiator.
Then at the absolute peak of our hierarchy sits CPT 19306, the urban-type radical mastectomy. Now this code is rare, but it's critical you know it. It requires the complete resection of everything we just talked about: breast, pectoral muscles, axillary nodes, plus the deep internal mammary lymph node chains situated behind the sternum. If you see internal mammary lymph nodes taken alongside a radical mastectomy, boom, you are looking at 1936.
Section 3. Modifiers and unbundling traps. Audit-proofing your claims.
Okay, let's talk audit-proofing. Breasts are paired structures, which means your laterality modifiers are strictly mandatory. You've got to append LT for the left side, RT for the right, or 50 for a bilateral procedure. On top of that, you're going to rely heavily on modifier 51 when you're reporting mastectomies alongside concurrent autologous or implant-based reconstructions. It's how you signal to the pair that multiple, distinct procedures happen during that same surgical session. Now, please pay very close attention here because this is a massive unbundling trap. Separate lymphadenectomy codes, specifically 38740 and 38745, are strictly bundled into your major mastectomy codes 19307, 19305, and 19306 when performed on the ipsilateral or same side. Why? Because those mastectomy code descriptions literally already state, including axillary lymph nodes. Billing them separately is a direct violation of coding guidelines, so don't do it.
You also need to be super cautious when you're utilizing the radioactive tracer or dye injection add-on code for sentinel node mapping. Tracking sentinel nodes is incredibly common, but you've got to check your NCCI edits. The guidelines dictate very specific edit differences when pairing these injections with a simple mastectomy, 19303, versus a code like 19307, which fundamentally already includes comprehensive node removal. Always verify your bundles.
Let's put this into practice. Section 4, Operative Report Case Studies, Applying the Logic.
Theory is a great foundation, but let's test your practical application. Our first operative report describes a 61-year-old female with invasive carcinoma undergoing a complete left mastectomy. The surgeon performs an end-block removal of levels I and II axillary nodes, but explicitly states the pectoralis major muscle is completely preserved. So based on what we've covered, what code are you submitting?
When you scan those operative notes, your eyes should instantly lock onto those key phrases. We have a mastectomy and we have nodes removed. That immediately bumps us past the simple 19303. But wait. The explicit documentation that the pectoralis major muscle was preserved, that is your absolute stop sign. It completely prevents you from escalating up to a radical 19305 code.
Therefore, the correct, perfectly compliant reporting for this encounter is the modified radical code 19307, with the LT modifier for the left side appended to our breast cancer diagnosis. The node removal justifies the 19307, but that spared muscle keeps us firmly out of radical territory. See how perfectly that maps out?
All right, case 2 escalates things significantly. Here we have a patient with advanced left breast cancer undergoing a radical removal of the breast, both pectoral muscles, and the internal memory chains. At the exact same time, the surgical team performs a concurrent single pedicle tram flap reconstruction. How are we coding this complex session?
Once again, we isolate the anatomy. Both pectoral muscles removed means we're looking at least a 19305. However, the resection of those internal memory chains pushes our primary procedure to the absolute maximum complexity. Meanwhile, that concurrent tram flap reconstruction is going to trigger our multi-procedure modifier rules, since it's a distinct restorative procedure performed in the exact same session.
Because of this specific combination, we correctly report the complex tram flap reconstruction first with 19368 LT, followed by our highest tier urban radical code 19306 LT with modifier 51 attached to indicate multiple procedures. And just like that, you have perfectly captured the massive anatomical resection and the reconstruction without unbundling a single thing.
Section 5, Masterclass Summary and Teaser. Looking ahead.
To wrap this up, whenever you're auditing a mastectomy note, just ask yourself this sequential logic. First, were the axillary nodes taken? If no, it's 19303. If yes, ask, was the pectoralis major removed? If no, it's a modified radical 19307. If yes, it's a radical 19305. Finally, were the internal memory chains resected? If yes, you've reached the urban radical 19306. Keep this decision tree etched in your mind, and I promise you will never pick the wrong code again. So think about it. If missing just one spared muscle in an operative report changes your entire reimbursement profile and triggers an audit, what else might be hiding in plain sight in your notes? Are you ready to master the incredible complexities of tram, diep, and latissimus dorsi autologous flaps in our next session? We are going to break down microvascular anastomosis and so much more. Thank you for watching, keep coding with confidence, and make sure to subscribe to Decode Healthcare with Harshal. See you in Part 12.